Welcome to the Deep Dive. We're here to cut through the noise on major health topics, giving you the insights that really matter. Today, we're tackling something super common. I mean, it affects millions, but people just don't talk about it enough. Urinary incontinence, UI.
It really is a critical topic, and the sources we looked at are crystal clear. UI, that involuntary leakage of urine, it's way more than just an inconvenience. It can seriously impact quality of life. We're talking physical activity, psychological well-being. It's a genuine health issue that, well, it needs attention.
Absolutely. So, our mission today,
Yeah.
a proper clinical deep dive. We're to break down the four main types: stress, urgency, overflow, and mixed. We'll walk you through the simple but really crucial office tests for diagnosis, and then map out the specific management strategies for each one.
Yeah, and to really understand UI, you've got to appreciate where it comes from. It's a broad range. Could be physical changes, like after childbirth, or just aging affecting the pelvic floor and bladder, but it can also be tied to bigger things. Think diabetes, neurological issues, even some common medications like diuretics.
Okay, so let's unpack this. Before we even start thinking about diagnosing a chronic type of UI, there's like an immediate first step. The sources really hammer home. You absolutely have to check for a urinary tract infection first, a UTI.
That's non-negotiable. It has to be the first check. Because a UTI, it can mimic UI symptoms almost perfectly. You get that sudden frequency, urgency, leakage.
So what are we looking for in that first test, the urinalysis, that basically screams infection?
Well, you're looking for specific chemical signs, things like nitrites, leukocyte esterase, signs of inflammation, bacteria. And if the urine culture comes back positive, confirming the UTI, the path's clear, treat it. Appropriate antibiotics. But, and this is really key, if the leakage keeps happening even after that infection is totally cleared, then you start the full workup for chronic UI. It just underlines that UI isn't always about infection, even if one was there initially.
Right, that makes sense. Deal with the immediate fire, then see if the building itself has a problem. So if the urinalysis is negative or, like you said, the leaking continues after UTI treatment, what's next in the office?
Okay, so negative culture or persistent symptoms post-treatment. Then we move straight to a really focused history, a physical exam, and two really essential office tests. These tests are fundamental because they help us figure out how the leakage is happening. Is it a support problem, or is the bladder just not emptying right?
Right, so two main tools to figure that out. Let's start with the one that checks for, like, a structural issue when there's pressure.
That would be the urinary cough stress test. It's beautifully simple, actually. The clinician just watches carefully to see if any urine leaks out when the patient gives a forceful cough. Often done with a full bladder or maybe standing up, just to really increase that abdominal pressure if you leak right then. That tells us quite a bit about the pelvic floor support.
Okay, clear leak under pressure. And the second key test. That focuses more on the bladder's main job, emptying itself.
Exactly. That's the post-void residual, or PVR. It measures how much urine is still left inside the bladder right after the patient tries to empty it. Usually done quickly with an ultrasound, non-invasive. This one's like a diagnostic lighthouse, it tells us. Is the bladder actually emptying, or is it holding on to urine?
And if you're trying to quickly get your head around the numbers, what's the crucial cutoff point for that PVR? What's normal versus concerning?
Generally, a normal PVR is considered less than 150 milliliters. That number is really important because if the PVR is way higher than that, it immediately points us towards an overflow issue, a retention problem. If it's normal, well, then we know the problem isn't emptying. It's more likely the bladder being overactive or just not well supported.
Got it. And beyond those physical tests, you also rely heavily on what the patient reports, right? You mentioned avoiding diary. Why is that sometimes even more helpful than just asking questions?
Because it captures the reality, the pattern over time. A diary tracks when you drink, how much, what you drink, when you feel that urge, when you actually leak. It helps us docs see patterns the patient might not even realize, like, oh wait, all my really bad urgency hits about an hour after my morning coffee. Things like that.
And we also need to remember the bigger picture, the patient's overall health situation.
Absolutely. You have to consider things like functional limits or cognitive impairment. Someone with, say, severe arthritis might physically struggle to get to the bathroom fast enough, or someone with dementia might not recognize the signals. That's a different kind of management challenge, separate from the bladder mechanics themselves.
Okay, let's shift to classifying these types, starting with the one most people probably think of: stress, urinary incontinence, or SUI. This is the structural one, right? Leaking specifically when you increase pressure, sneezing, laughing, jumping.
Exactly. SUI is essentially a mechanical failure. The support system around the urethra, primarily the pelvic floor muscles, just can't hold things closed when that pressure hits suddenly.
And what might you see during the physical exam that points specifically towards SUI?
Well, you often find general pelvic muscle weakness. Sometimes you might see pelvic organ prolapse, like a cystostole where the bladder has dropped down a bit into the vagina. But a key finding technically is something called urethral hypermobility.
Urethral hypermobility. Okay, break that down for us. Sounds technical.
It just means the urethra and the bladder neck are, well, moving around too much when the patient strains, like during a cough or bearing down. Doctors look for a significant downward shift from its normal position. It's basically a visual clue that the supporting tissues aren't doing their job properly, they're maybe a bit stretched or weak. And it's interesting, the sources mention this. Historically, you might have heard of the Q-tip test.
Vaguely, yeah.
They used to actually insert a cotton swab into the urethra to measure the angle change. Thankfully, with better techniques now, that uncomfortable test usually isn't needed anymore.
Okay, so putting it all together for stress UI, diagnosis is pretty clear. You need a positive cough stress test, they leak under pressure,
Yeah.
and a normal PVR, meaning the bladder itself is emptying just fine.
Exactly right. The problem is keeping the urine in, not getting it out. So management logically follows. Focus on strengthening or supporting those structures. First line is always conservative. Pelvic floor physical therapy, think cables, but often more targeted, plus behavioral stuff like managing fluids, maybe weight loss if needed.
But if PT isn't quite cutting it, then you move towards more mechanical or surgical solutions.
Correct. Non-surgically, you might try an incontinence pessary. That's a device inserted vaginally that basically props up the bladder neck area. Or sometimes urethral bulking agents can be injected. These kind of plump up the urethral lining to help it seal better.
And if those don't work or aren't suitable, surgery becomes a common option.
Yes, and the standard procedure here, the real workhorse, is the midurethral sling. It's usually minimally invasive, placed vaginally. It sits underneath the urethra, kind of like a little hammock. The idea is it provides just enough support to keep the urethra closed during those moments of high pressure, like a cough or sneeze. Dynamic support.
Okay, that covers the structural failure side. Now let's slip to the other end of the spectrum. If stress UI is like faulty plumbing, maybe urgency incontinence, UUI, feels more like faulty wiring. That sudden, overwhelming urge to go right now, often leading to leakage because you just can't hold it.
That's a good analogy. UUI is very different. It's tied deeply to how the bladder behaves, its signaling. The patient's history might reveal triggers bladder irritants like too much caffeine, alcohol, or maybe underlying medical conditions that affect nerves like MS or spinal cord issues. On exam, sometimes you might see signs of vulvovaginal atrophy, especially post-menopause, which can contribute to irritation.
I see. So the diagnostic picture flips too, right? Since it's not about weak support, the cough test should probably be negative.
Generally, yes. The pattern for UUI diagnosis is typically a negative cough stress test, no leak with coughing, but crucially, also a normal PVR. Remember, the bladder empties okay. It just decides to squeeze way too often or too strongly at the wrong times.
And this ties directly into something called overactive bladder, or OAB. How do UUI and OAB relate?
Great question. OAB is defined by that symptom cluster. Urinary urgency, usually with frequency, maybe getting up at night, that strong gotta go feeling. But here's the key difference. Not everyone with OAB actually leaks urine. If that intense urge does result in involuntary leakage, that's when we call it urgency incontinence. So you could say all UUI is a type of OAB, but not all OAB includes incontinence.
Okay, that clarifies it. So the management focus shifts away from physical props and more towards, what, calming the bladder muscle or its nerve signals.
Precisely. Behavioral strategies, pelvic floor PT, they still play a role, absolutely. But pharmacotherapy medication becomes a major player here. We use drugs designed to calm down that overactive detrusor muscle, the main muscle that squeezes the bladder empty.
Can you simplify how those main drug types work?
Sure. Think of the bladder muscle as having specific docking points, receptors. When certain signals hit these receptors, the muscle contracts. Antimuscarinic drugs work by blocking some of those key receptors, basically telling the muscle, whoa, slow down, don't squeeze involuntarily. Alternatively, beta agonists work differently. They actually help relax the bladder muscle, allowing it to hold more urine comfortably without those premature contractions.
And we often hear about topical treatments being helpful for UUI, particularly for women.
Yes, that's where topical estrogen comes in, especially for postmenopausal women. Estrogen receptors aren't just in the vagina, they're in the bladder, the urethra, the pelvic floor muscles, too. So, using low dose topical estrogen can improve the health of those tissues, reduce irritation, and sometimes significantly improve bladder function and UUI symptoms. And if those don't work, there are other options, like Botox injections directly into the bladder muscle to relax it, or even nerve stimulation therapies for tougher cases.
Right. Okay. Now for the final two types, starting with overflow incontinence. This sounds like the bladder just isn't emptying properly, leading to constant fullness. The symptoms seem maybe more subtle, like dribbling, leaking, needing to go often, especially at night, maybe a weak stream.
Exactly. And this is where that PVR test becomes absolutely central. Overflow incontinence is basically defined by an elevated PVR. It confirms they are retaining a significant amount of urine after trying to void. The bladder is essentially overfilled like a blocked sink, and it just kind of overflows, dribbles out.
And what are the main reasons why this happens? Why would the bladder not empty?
It generally boils down to one of two things. Either there's a physical blockage, what we call bladder outlet obstruction, maybe severe pelvic organ prolapse pinching the urethra shut, or scar tissue from surgery, sometimes even a tumor. Or the second reason is that the bladder muscle itself is too weak to contract effectively. That's detrusor underactivity. The pump isn't strong enough. This often happens because of nerve damage, think conditions like diabetes, stroke, MS, Parkinson's things that can affect the nerves controlling the bladder, typically the S2, S4 nerve roots.
So the management strategy has to directly address whichever of those two is the cause, relieve the blockage or help the emptying.
Exactly. If it's detrusor underactivity from nerve damage, often the main solution is intermittent self-catheterization, where the patient learns to empty their bladder manually with a catheter on a schedule. If the cause is an obstruction, like a prolapsed bladder blocking the way, then treatment focuses on relieving that blockage, maybe a pessary to lift the prolapse or surgery to repair it.
Okay, that leaves us with the last category, mixed UI, which, as the name suggests, is just a combination.
Pretty much. It's having symptoms and signs of both stress incontinence and urgency incontinence. Very common, actually. Diagnostically, you'd look for evidence of both things happening. So typically, a positive cough stress test showing the structural leak combined with that classic history of sudden, strong urges. And usually, because the main issue isn't with tension, the PVR should be normal unless there's some other complication going on.
And the treatment, logically, would be a mix and match approach, too.
Precisely. You have to tackle both problems. So it's often a combination strategy. Lifestyle changes and pelvic floor therapy are foundational for both aspects. Then you might add things like a pessary or bulking agents for the stress component, and potentially medication like antimuscarinics or beta agonists to manage the urgency component, attacking it from both sides.
Okay, wow. We've covered a lot of ground. The four distinct types, the absolutely critical first step of ruling out a UTI using those key office tests like the cough test and PVR, and then how management really needs to be tailored, depending on whether it's fundamentally a structural support issue or more of a bladder behavior neurological issue.
That's a great summary. And, while most cases can be diagnosed and managed effectively with that focused history, the physical exam, and these simple office tests, it's also important for listeners to know when things might need to escalate to more complex testing. Multi-channel urodynamic testing or complex systemetrics, that's the next level up.
And when would that be necessary?
Generally, it's reserved for specific situations. If the diagnosis is still really unclear after the initial workup, or if the patient's symptoms just don't seem to match the objective test results. Also, if the initial treatments haven't worked at all, or if the patient has a complicated history, like having had previous surgery for incontinence, that's when you might need that deeper urodynamic dive.
It's really clear that managing continence involves this fascinating interplay between, physical structures, muscle function, and crucially, those nerve signals. So here's a thought to leave you with. Considering how much current treatment focuses on either physically supporting structures, like with a sling, or chemically calming the bladder muscle, what might the future hold? Could we see interventions emerge that more directly address, maybe even repair, those complex nerve pathways that get damaged in conditions like diabetes or MS? Something to think about.